Welcome back to Between Two White Coats, a podcast designed to help you be the healthiest version of yourself. I'm Dr. Michelle Plaster, a family medicine doctor.
And I'm her co-host, Amber Foster, a family nurse practitioner. In our combined 30 years in medicine, we've seen a lot.
We're discussing key issues surrounding health and wellness, answering some of our biggest questions, overcoming health obstacles, and giving patient-centered advice in hopes of educating you and providing the tools you need to live a healthy life.
If you find our podcast helpful, please consider subscribing so you don't miss an episode. And don't forget to leave us a 5-star rating and review. This will help other people find our podcast.
Thanks for joining us. We look forward to serving you. Hey, welcome back. Thanks for joining us. Amber and I have a great topic today. Let's jump right into hormone replacement therapy, menopause, and treatment for this. And
it's a lot.
It's a lot. And if you're considering not listening to this, I'm going to ask you to just stay tuned for about 20 minutes with us, because this is something that gets ignored. It gets ignored too much. We think we have to stomach through things and have a poor quality of life when we don't.
I think it's becoming more of a topic, though. I feel like, at least in our practice, what I see is someone will come to me and then they start feeling so much better, and then they tell their friends.
Oh my gosh.
And so now I do this a lot every day, which I'm so grateful for, because
I'm pretty sure there are book clubs that have a statue of Amber.
I told them if I don't start getting invited to dinner, I'm going to be very upset. But
and it's interesting because there was zero marketing that went into
Yes.
Amber creating an entire practice of hormone replacement, but it was really women saying, "Oh my gosh,
I don't feel good. What is wrong?"
And my life has changed remarkably for the better, and they want to tell other people, you don't have to feel bad either.
Yeah.
And so word of mouth, really, but it also tells us what a big problem it is.
Yeah.
There are tens of thousands of women who are suffering through menopause symptoms and thinking that they have to, and they don't.
So initially you said suffering through, and that is, and that's kind of what is expected. And I feel like we'll talk a little bit about the Women's Health Initiative, and it might be okay just to mention it now.
Let's just jump the devil that has made this more of a challenge.
Well, and of course, too, anytime I feel like women want to talk about menstruation, or, people will hide a tampon, go into the bathroom, knowing that every woman is menstruating.
Right.
Why are we still doing that?
We have such shame
yes,
around everything related to our female organs.
Yes. So, we're the ones that are literally giving birth.
Yeah.
And giving life, and we're still ashamed of that. We bleed once a month.
Right. I would just like to say, if you struggle with the word uterus and it makes you uncomfortable, you came from one.
Yeah.
You all came from one, every single one of you. So we just need to get comfortable talking about what's going on here.
And so I feel like a lot of times we will shoulder we're just supposed to have hot flashes, and we're supposed to have abnormal weight gain, and we're supposed to feel bad at this age because that's what you do.
And we can't ask for help.
Yeah.
Yeah. So the Women's Health Initiative sounds like an amazing thing. Doesn't this sound like when we all got together and decided that we were going to make a positive difference for women? And I think maybe that was the attempt, but this was a research study that was done
started in 1991.
And then, for 10 years or so, it was a big study, and the intention was to really look at hormone replacement therapy, and to really try to summarize the benefits
Do's
and
and
the
don'ts.
risks of hormone replacement therapy. But then some things, and, not to blame the study, although the study had a number of flaws, but we also tend to want to oversimplify things, and we want to say hormone replacement therapy, good, bad. And the Women's Health Initiative really made us say bad. And so the outcome of Women's Health Initiative was that we started thinking hormone replacement therapy was bad. Why did that happen? How did we come to that conclusion based on this one study?
Well, there were multiple reasons, but you mentioned the study flaws, and I think that just if you looked at the sample status of patients, all their comorbidities that they had already, of course they were horrible candidates. The ones that I'm typically treating are patients that are perimenopausal, menopausal, and we'll we'll define that here in a little bit. But most of the patients in this study already had a comorbidity. They were 10 years past when we would have started treatment anyways.
So if we want to talk about,
they weren't great candidates.
Should you get hormone replacement therapy? Let's study people who are coming and asking for it. And those are people who are struggling through menopause, around 50 years old.
Yeah.
Well, we had 80 and 90 and 95-year-olds in this study who had been without hormones for 30 years. And then we were looking at things like increased risk of heart disease. Well, 80 and 90-year-olds have heart attacks. They have medical issues.
Yeah.
Gosh, I hope I'm old enough I hope I live to see what medical issues I might have when I'm 90. So you don't enroll someone in a study who's 90 if we're trying to look at what we might apply to 50-year-olds.
Yeah. But I have a student with me currently, and I actually did some hormone therapy. I had a consult yesterday with a patient, and she was like, "But aren't hormones bad? That's what they've taught me in school." And I'm like, "We're still teaching this in school."
What?
Like, yeah. So
Yes.
I feel like just in general, if you ask, I like to call it the gen pop, but if you just ask people in general, people are scared of hormones, and it's because of this.
And medical providers are scared of hormones. So this study, and then I want to come back to the medical providers being scared. This study made us believe that there was an increased risk of heart attacks because of hormone replacement therapy. When we have looked back at the study and said, if you take 80 and 90-year-olds and you put them into this study and you see more heart attacks, we can't blame the estrogen. We might have wanted to blame other things. And that there was an increased risk of cancers, and we've also been able to find some of the flaws with that. Now, we'll talk about who hormones are right for and who they're not right for, but I don't think we can take the summaries of the Women's Health Initiative to say hormones bad. And unfortunately, we still have healthcare providers. Your student is a very smart nurse, and she's in nurse practitioner school, and we have these smart healthcare providers who are just sort of putting hormones high risk and going to increase your risk of heart attacks and cancers. And that's not true. And they have attempted to replicate the Women's Health Initiative over the last 20 years, and they cannot get the same findings. And most of the time, if we can't repeat a study with multiple attempts to do so, we start saying this study can't draw these conclusions. Yeah. And yet it got out there. You know, we let
women
all of that out there.
Pull off of those therapies.
And so when all that happened, it was like, oh, stop taking, and abruptly stop taking, and then never start. And I just had a patient yesterday who's talking to me about her primary care doctor. And then she's like, oh, I have a wellness visit with my primary care doctor in October. And this woman drove over from Athens, which is like 30 minutes from us, to see me. And the whole time my brain is going, why are you here? Like, you clearly have a primary care doctor you're clearly happy with. I think that's fabulous. And so finally she says that she's here because she needs a doctor who is willing to refill her bioidentical hormones from her compounding pharmacy in Athens. Well, this is a pharmacy that we prescribe to a lot. Know the pharmacist there because we send people there for compounded hormones. And so the pharmacy will sometimes tell patients who have a prescription and their doctor won't renew it. And they're like, oh, please. Like Amber said, her grandma says, don't pry my hormones out of my dead hand. Like, I am going to take these forever. I have no quality without them. And so women are like, I've been on this for a while. I don't want to stop taking it. I understand any risk that exists, and I would like to stay on this medicine. And their doctors won't prescribe it. So they're finding us to simply write them the prescription, do the labs. And all due respect to the doctors, if they don't know how to do the labs and follow and make sure that everything's being done properly, then they're being very responsible. But that is now the third person that I've met, and you see more of them than I do, that the pharmacy sent us because their doctor wouldn't refill their medicine.
Yeah.
So talk to me then when we're saying who's it right for, who's it not right for, and some of the carry forward that has been misinformation from the Women's Health Initiative. Who is hormone replacement therapy right for?
So it's for perimenopausal and menopausal women. That range of age is is so varied on patients. Like I have had a 37-year-old in perimenopause, and I have had a 55-year-old patient who is still having a period every month. So like it is so varied on the patient. So often it is, what symptoms are you experiencing, and could this be hormones?
So maybe before I even jump you into that, let's talk about what happens in a person's body in perimenopause.
So I'm going to give like a really brief. And I think this is interesting too, because when I talk to patients about this, it's a lot of education. By the time like they look like a deer in headlights, by the time I'm halfway done with my whole spiel on HRT, because it's a lot of information, but I want them to feel educated so that when we are making decisions, because it is a we thing when I am doing hormone replacement therapy, because a lot of these are subjective symptoms that I cannot see. So it is things that they are experiencing. I can get labs, and labs do tell me something, but I also treat symptoms. I don't always just treat numbers.
Well, and let me just tell you that the only lab I hate more than like an ANA to say whether someone may or may not have lupus, because it's just so many shades of gray, is estrogen, progesterone, hormones, because there's so many shades of gray. It's a large range. We talked in our men's health episode about testosterone and the large range that someone's normal might look normal, but it might not be normal for them. Yeah. That happens in female hormones as well. And then based on your cycle, there's a totally different estrogen level at one time of your monthly cycle than a different time. Yeah. And if you're having abnormal periods or irregular periods, we don't really know where you are in your cycle. So the numbers could mean a lot of things. Yeah. And it's not very black and white.
So when I release labs to Portal, we have patient Portal here, and so patients can see their labs, and I'll say, okay, well, this is the recommendation. And they're like, well, what are my hormones? And I'm like, well, they're low. Like they're low for you, because it doesn't really like alert red like it would if your blood sugar was 300. It doesn't do that for hormones, like because the range is just so large.
And it's a lot of informed interpretation when it comes to hormones. So for anyone who's just like, hey, can you draw my blood and tell me if I'm in menopause, and then we can make all the decisions based on my blood? No, that's not how it works. And like Amber just said, menopause is a clinical diagnosis. It's not a lab diagnosis. We diagnose a person as postmenopausal when they've gone a year without menses. That is a struggle sometimes, because people may have stopped menstruating for other reasons. Maybe you had an endometrial ablation. Maybe you've had a hysterectomy. They left the ovary, so you still had estrogen, but you don't have a uterus, so you don't bleed.
IUDs.
Yeah, maybe you have an IUD that stopped you from having periods. So if you haven't been a person who's had regular periods, then you're not going to be able to use just the fact that I was like clockwork every month and now I've gone a year. And it's not typically like, and it stopped one day and then I didn't see it for 366 days. And then I said I was postmenopausal. You might not have a period for 6 months and then you have one. And then you might not have a period for 3 more months and then you have
It'll
one.
be like 363 days. And then I have a patient that I have a period and they're like, what?
And we kind of consider the clock starts over.
Yeah.
Like if you haven't gone a year without bleeding, then you're still perimenopausal. You're going through the hormones are changing.
Just in general, I think it's interesting when I start talking about like phases of just menstruation, so people can kind of get a broad, this is a big picture. This is lots of science, but I'm going to just kind of make it simple. But when you are menstruating, so the first week is your menstrual cycle or the menstrual phase, and that's the first day that you're actually bleeding. And that's when your uterine lining is shedding, or your endometrial lining is shedding. The second phase is the follicular phase, and that's when estrogen, testosterone kind of are a little bit higher. People have a little bit more energy during that phase. They feel a little bit stronger. The ovulatory phase, typically days 14 to 17, and estrogen, testosterone peak then as well, and then progesterone starts to rise just in case you get pregnant. And then the luteal phase is when everybody has the PMS symptoms and the cravings and they feel bad. And then progesterone will rise during that time, and if you become pregnant, they continue to rise, and if you don't, then you bleed. So it's this essentially cycle of up and down progesterone. The first 2 weeks are essentially more estrogen driven. The last 2 weeks are more progesterone driven. But that's kind of just a very, very basic, that is what a period is. That is what
I'm
menses.
just picturing the graph that's in every single textbook that I've ever been forced to read. And you see this increase and drop of each different hormone at a different part of that cycle. And so it's not just, and here the levels are high and here they're low. The body's an incredibly complex thing. And so as Amber was explaining, these levels have to do what they're supposed to do to maintain that normal cycle.
Yes.
And then menopause comes and our body says, hey, we don't have to have the uterus ready to implant a baby at any time. And so we don't have to maintain these hormones. The ovaries aren't going to sustain the estrogen and progesterone like they once did. And the levels start to drop off.
And estrogen being the one that tends to cause the most symptoms that patients complain about.
And it is different symptoms for estrogen and progesterone and DHA and testosterone. And so all of these different things, we kind of say, well, based on these symptoms, we suspect you might need more of this or that in your hormone replacement. Yeah. But so estrogen and progesterone are changing. That there will create decreased bleeding or irregular periods. And in this perimenopausal, it can be all over the place. You could have high levels one day, low the next.
You don't know.
Yeah. And so when these hormones decide to just kind of go rogue, what are the symptoms that tend to come with that?
The top 5 I tell patients that I see in clinic. So this may not be like everybody in the whole wide world, but the ones that I hear the most often are hot flashes. Most all the time, like I'll sit there and I'll see patients just start having a hot flash in front of me. They're like, oh, one's coming. They're miserable.
And horribly uncomfortable.
Yes.
Like we should not, I would like for every person to feel like out of nowhere they just got set on fire from the inside.
That's what I hear.
Terribly uncomfortable, break into a sweat, hair wringing wet for some people. It's really...
Yes. And I have a lot of patients that'll say that it's embarrassing.
Yes.
And then, of course, it's happening in the evenings, like at night. And so it's waking them up. It's disturbing their sleep.
We have this cycle of our hormones that is a day-to-day on a circadian rhythm. And so different things are supposed to happen at night. And so estrogen and progesterone levels can really vary at night, bringing these symptoms on even more. And insomnia can be a symptom of menopause of itself. I've had a patient who her really outlying thing was insomnia, and we treated with hormone replacement, and her insomnia was improved and changed her life. But imagine that every hour you're waking up feeling like you're drenched in sweat and you're on fire.
Yeah, and I have a lot of women that will say, they turn their air all the way down, they take off all their stuff, and then they wake up freezing, and then they put everything back on, and it's up and down all night.
Yeah.
So that's a big one.
So hot flashes, big one.
Yeah, and I think too, there's been a lot of commercials lately about the vasomotor symptoms. I don't know if you've seen them. I don't really watch a ton of television, but I have seen them, and it'll say vasomotor symptoms, ask your doctor, and that's what they mean. It's these hot flashes. And then brain fog, that one is very frustrating because I have patients that are, high level everything, teachers, moms, physicians, lawyers, all kind of people that are going through menopause, because every woman most likely will go through it, and they can't finish a sentence.
Yeah.
They
and a lot of people are familiar with pregnancy brain. We'll joke about pregnancy brain, where you've just lost your mental clarity and sharpness, and it's hormone related. And same thing here. Your hormones can help you with that focus and memory and ability to be cognitive and witty, and it goes away.
Yeah.
And it is difficult. You may not be functioning in your job as well.
Yeah. And then decreased libido, so decreased sex drive. That's a huge one. Abnormal weight gain. So a lot of perimenopausal women will gain weight around their abdomen. And let's just be real. As women, we don't want to be gaining weight anywhere, but it really makes us aggravated when we're getting belly fat. We're like, why do I have this belly?
This visceral fat is what increases our risk of heart disease more than gaining fat in other places.
Yeah.
So it is a health concern as well.
Yeah. And then vaginal dryness. That also increases risk for UTIs. It makes sex painful. So those are the top 5 that I typically see the most. And so, and those are the most that patients complain about.
And at what point should someone be talking to their physician about these symptoms if they're having them?
As soon as you start having them, because I can fix it.
As soon as it's uncomfortable for you. As soon as it's uncomfortable for you. Why would you leave yourself suffering? I really people want to quantify when should we treat this? When should we address this? When it is decreasing your quality of life.
Yeah. Yeah, I would say I tell patients I can fix that. That's an easy fix.
Yeah.
Let me just help you. And I think sometimes we think we're supposed to suffer. I joke with Scotty all the time. Her birthday and my birthday are about 3 weeks apart, and we are not 45 yet. And I'm like, listen, I'm not even going to get labs. I don't even care. We're getting on hormones at 45 because I am not doing all of that.
Full transparency. About 6 months ago, I went to Amber and was like, I think that we need to start me on some hormone replacement therapy because I'm 51 and like 50 is the typical age for menopause, and my body read the textbook, and at 50 things changed. And I remember saying to Amber, and for me, I gratefully have not had hot flashes, haven't really had issues with sleep. It was irritability.
Yeah.
I was like, why is my husband breathing so loud? Does he have to breathe? And so then I said to Amber, I think I need some hormones. And she was like, let me call the pharmacy right now.
Let me call my friend.
I'm thinking, what have I been acting like at work?
I got this. We'll
she
get this
was
done
right
today.
on it. Yeah.
There's a lot of other hormones that come into play. So we mentioned estrogen, progesterone, testosterone, but I'm just going to read through so that you can kind of see, or people can hear, but like insulin, ghrelin, leptin, DHEA, FSH, LH, cortisol, melatonin, and thyroid, like all of that also has to do. So like, it is not like, oh, let me just get your estrogen. I'm typically getting a very large panel on patients.
And people need to recognize in the endocrine system, you can't move one domino without other dominoes getting affected.
Yeah.
And so when you hit the domino, a number of them fall. And you may notice that other hormones that do not seem like thyroid or other things that do not seem related to menopause actually get affected because of the change in your estrogen, progesterone, and some other hormones in your body.
So it is a pretty comprehensive, like I'm not just like, oh, here you go, whatever.
Yeah. And we want to make sure, because sometimes you could start diagnosing yourself. Like people will be like, I must be in early menopause. I'm age 40 and I'm having all these menopause symptoms, and it's their thyroid.
Yeah.
And so it's important that they come in and talk about it because it wasn't their hormone levels at all.
Yeah.
It was something else.
And
we don't want you ignoring that.
Yeah. And often that's what I find. I'll find, like, if someone younger comes in, like I had one lady in particular, and she was like, it has to be my hormones. And she was in her maybe mid 30s. And I was like, maybe it is, but let me get this other stuff. And she was severely anemic. And so she'd just been walking around fatigued thinking, and her periods were off because she was so anemic.
Yes.
And so we fixed the anemia. She's like, oh my goodness, it wasn't my hormones. I just needed an iron transfusion.
Right.
Right.
And
big
so
deal.
Getting the diagnosis right and making sure that we are identifying those symptoms correctly to assigning them to the correct thing. And then, so if you're having issues, talk to your primary care and let's figure out what's going on. And then when we recognize that you are perimenopausal, meaning you're getting the changes in your hormones, but you haven't been a year without menses yet, or we can look at an FSH level and really see if you don't bleed, if you don't have a uterus, or for those reasons mentioned, you don't have menses, then we can look up specific labs and see that you are actually postmenopausal.
Yeah.
But if you're going through these symptoms, then there are things we can do about it. What can we do? And there's a lot of conversation that people are saying, do I need bioidentical? Do I just take the prescription that I can take in a pill? Why would I use a cream versus a pill? What is all of this and how do you navigate it?
So it is very patient specific. Like I very rarely do I have two patients that get the exact same prescription. And that's because I'm looking at their symptoms. I'm looking at a number of labs, mainly symptoms truly. But so bioidentical hormones pretty much just mean what our body makes.
Yeah. So biology, identical, it's right there in the name. And so this is trying to formulate something as close to what our body makes. It's plant derived and as close to what our body makes as possible. This is not the kind of stuff that was used in the Women's Health Initiative studies.
Yeah.
And typically what we'll do with the bioidenticals is have a compounding pharmacy make it so they can tweak down to very small changes the exact amount of estrogen, progesterone, testosterone, other things that can then be put together into this compounded formula.
And I will say, so there are medications like pills that are bioidentical, but those are the FDA approved ones. So the patches, the pills are FDA approved. The compound creams are not FDA approved, but I do use them. I feel like that's a discussion to have with a patient and to say, hey, you need to know that this is what we're doing. I really haven't seen a lot of risk associated with using a compound versus a pill. It truly is patient specific, and depending upon, and some of it's cost effectiveness too. Like, the compounds tend to be a little bit more expensive and insurance doesn't cover those. So it depends on the patient if they can afford the compound. So lots of discussions.
Coverage isn't great on even the pills and the FDA approves. They're often tier 2 or 3, and that might be a $10 difference than what the compound is going to cost. So it's worth it if you're interested to kind of do your research and see what it's going to cost you.
There's pellets are kind of a newer thing, so the same type of thing, like it's a compounded thing that they actually, we don't do those yet. We will hopefully be doing those very
Yes.
soon. But where we can actually just put a pellet in, and it gives you like this slow, continuous amount of hormone within about 3 months range. But those are safe as well.
And convenience to pellets is
yeah.
that it's really, it's injected under the skin, and it slow releases over time, so you don't have to worry about it.
Yeah.
And then you get another one injected
Yeah.
when that one is done. The disadvantage, I would say, is that people want to get regulated on a certain amount first, so that, because once we put the pellet in, you're going to get that amount of medicine, and so we'd want to have that amount figured out for you, because there is some trial and error. When we meet someone and we're starting them on hormone replacement therapy, we get a lot of labs, but then we help the way that we have chose to do it with the patient's buy-in is we lean toward the bioidentical compounded. And we can be more specific. We can meet people where they are. We can treat their specific symptoms, and then we can tweak it, because we might think we have it right, and then 3 months later,
Yeah,
we're gonna
I do it in 90
repeat-
days.
Every
90 days.
Every 90 days.
I see patients every 90 days for that. And then
And if you're still having certain symptoms, maybe your lab levels look okay, but you're still having certain symptoms, we might go, well, that symptom is more based on
Estrogen.
estrogen, so let's up your estrogen a little. Or
Yeah.
that's more based on testosterone, so let's change your testosterone level a little
Yep.
bit. So then we tweak it with the compounding pharmacy, and the pharmacist then gives them a new one, and 90 days later, we're watching
And then, of course, too, which we say this over and over, but like we also talk about like lifestyle things and diet and stress management, because all of that affects hormones, and so those are other things that I talk about with patients during hormone replacement therapy. The patients there's a few caveats for things where it's just going to be a no-go for me. If you have a family history of a gene-positive breast cancer, now we offer some gene testing here. So if you opt to have the testing and your insurance covers it, or if you want to pay out of pocket for it, but if there's a gene-positive breast cancer, then you do not want to do anything estrogen.
Estrogen-dependent cancers feed off of estrogen, and we would be giving you estrogen and hormone replacement. And so we don't want to give you estrogen if you're high risk for an estrogen-dependent cancer.
Yeah.
I think most definitely. And if you've not had that kind of gene testing, the estrogen-dependent cancers are typically ovarian, breast. And so you want to make sure anyway that you're getting your mammograms. But if you're on hormone replacement therapy, make sure you're getting your mammograms as well. You don't want to be high risk, and make sure that you're screening.
And then smokers, just like you would with before we were all perimenopausal and menopausal, there are risks associated with patients who are smokers.
Estrogen can increase your risk of blood clots,
Yeah.
and smoking increases your risk of blood clots. So we have found that the risk of clots, whether it be DVTs, pulmonary embolus, strokes, will go up if you're on estrogen and you're a smoker.
Yeah. A couple of things that I think people don't realize is that estrogen is heart protective. It's also bone protective. So those patients who are at risk for osteoporosis or osteopenia, so those are patients that I'm like, hey, we may need to treat your estrogen.
And I have a family history of osteoporosis. I do not have a family history of estrogen-dependent cancers or as much heart disease. And so I actually feel like taking hormones for me is helping protect me from what may happen in the future, not increasing my risk. And making it okay for my husband to breathe again.
I know, and he's so thankful for that.
Yeah. So I hope that this has given you guys some good information on hormone replacement therapy. Amber's certainly become quite an expert on it in her desire to help women through these difficult challenges that can happen in the perimenopause and menopausal states. And then I think just kind of finishing up and making sure we address this, how long should people stay on hormone replacement therapy? And the scientific answer to that is the shortest amount of time that you need it, and the lowest dose that is of service to you. And so we don't want to give you more for longer than what you need. But again, very person specific. What is the amount of time that you need it? And I think that this needs to be a decision made between, like all the decisions, between patient and provider, so that you can do what's in your best interest.
Yeah, so come see me. If you're perimenopausal, menopausal, I got you.
Yeah, we can save you from all of that.
All of it.
All of that. Thank you so much for joining us today.
We like to end you on a good note, and today's Tell Me Something Good comes from Dr. Brian Kirkland.
Well, I'm going to brag on my kids a little bit. I have 3 children. Luke is 16, he'll be 17 in February. Jackie's 14, and Joy is 9. So my kids go to Providence Classical Christian School, and every year they have a speech meet. So basically, all the students have to give a speech, deliver a speech, and then they kind of go through certain different rounds. And then they have a big competition with the finalists, and people are invited to come. So this year, Luke won in his category, his age group, in the upper school. Jackie won in the middle school, Now Joy has not yet had hers because the lower school is later. So Joy's
Lots
is
of
coming
pressure.
up. But
Lots of
Luke
pressure.
and Jackie are both winners of speech meet this year.
Incredible.
Congratulations, that is
That's a
something
big
good.
deal.
So something good is gifted children.
Yes, that's
We
right.
all have them. All of our kids are
They all have
gifted.
different gifts.
And yes, and Brian's are gifted at public speaking, which is a fantastic
Yes.
gift.
Thank you for joining us today. Until next time, take care of yourself.